All right, let's get into lower extremity 2, the review sheet. So, the longest, strongest, and heaviest bone in the body is the femur. If you wield it in class, it's kind of like a club when we grab those bones. So, it's an incredibly large bone in the body. The acetabulum is formed by what bones and what's the relationship? So, we have the ilium, the ischium, and the pubic bone. Now, the pubic bone is like medial and anterior. It's going to form 1/5 of it. The ischium is posterior and 2/5, and kind of lateral as well. And then finally we have 2/5 superiorly, which is the ilium. And that is actually, it's a little more than the other bones. So it's the largest contributor to the acetabulum is the ilium. What part of our pelvis do we sit on? That is going to be the ischiotuberosity, which we should know. The two alternative names for the hip bone. One is the innominate bone, and the other is the os coxae. And let's see, which condyle is larger? That is going to be the medial condyle. It's larger. It articulates with the tibia, and that bears more weight. That may be one explanation for why it is larger. Now, the patellar ligament extends from the apex of the patella down to the tibial tuberosity. It essentially anchors the quadriceps femoris to the tibia. The proximal tibiofibular articulation and anatomic position and true lateral. In both cases, the proximal tibiofibular joint is closed, at least when viewing it from those directions. It's superimposed is the basic way to understand that. The proximal femora and acetabulum in anatomic position. The proximal femora project posteriorly 15 to 20 degrees when in anatomic position. It's not until we rotate the feet medially that those femoral necks come into profile. The difference between the male and female pelvis, is that the female pelvis is broad and more wide as they give birth, right? That outlet has to be bigger. For a man, it is more compact, it is narrow and more vertical, typically resulting in a higher iliac crest. Let's see. Moving on, we'll go to the positioning question. So this chapter is just significantly faster. More condensed. There's not as much. This test should be pretty straightforward for you guys. That's my hope. All right, so let's talk about the knee. When we do a knee, we're going to do the AP, the medial oblique, the lateral, and then you guys need to also understand the sunrise and the tunnels. Let's talk about the AP first. When positioning an AP knee, we have to recognize that we have to measure the thickness of the pelvis, essentially, with the calipers that we have in the lab. Now, we don't do that. Most people just assume that there's a central angle to the phallus because everyone has a big bottom. But we want to open the joint space, so we have to utilize an angle. What is that angle? Now, those are ranges in your textbook or things you have to know. The angle is 3 to 5 degrees to phallus for people who measure greater than 24 centimeters. From 19 to 24 centimeters is a perpendicular beam. And for people who are smaller than 19, if you are less than 19 centimeters, then you get a caudal angle, again, of 3 to 5 degrees. So make a mental note of that. The centering point is always the same. It is 1/2 of an inch directly below the patellar apex. Forgive how loud my car is, y'all. Sorry about that. All right, for the medial oblique knee, we're going to stay centered the same place. We're going to stay angled the same way. All right, so nothing really changes in terms of positioning except that we rotate the leg medially 45 degrees. Now, in my experience, most people can't do that, so in order to achieve that type of rotation, we're going to have to put a sponge under the affected side and roll them away from us, and then have them rotate their leg in. That'll get you 45 degrees. All right, now, we'll go to our lateral. For our lateral knee, we roll the patient on the affected side and flex the knee approximately 20 to 30 degrees. If there is a suspected patellar fracture, we do not exceed 10 degrees. And I'll tell you, you'll typically review your AP and oblique, and you should be able to see that. There would also be significant swelling in the patellar region, so you would know before you go to flex it. And they would tell you too that hey, this hurts. Anyway, so don't flex it beyond 10 if you think there's a pressure. Roll them on the affected side. We're going to do a medial lateral projection. Medial lateral. We're going to angle 5 to 7 degrees cephalic now. Just kind of depending on the thickness of their hips, but there's always an angle on the lateral. You don't measure, you just use an angle. 5 to 7 degrees cephalic, and we are going to center 1 inch below the medial condyle. All right? So that is those are your common 3 projections you're going to do on the knee. All right? Now there's different variants at different sites, but for the sake of what I need you to know at this moment, those are your 3. Now, say you do a sunrise. We've discussed that. All I need you to do for this test is to recognize that a sunrise, what it looks like, to know that it's a tangential projection, and the most common method is the steady gas method, okay? Now, let's move on to the tunnel. To perform the tunnels, we need to understand that there's 2 PAs and 1 AP. We'll start with the Holmblad. So a Holmblad method is a PA projection of the tunnel, also known as the intercondylar fossa. All right. Now, you won't be doing evaluation criteria on this, but you will need to be able to recognize the different angles required to do this, in addition to like a diagram or things like that. You need to know that these exist, and there's multiple methods and what those methods look like in terms of how we get them. All right. So for the Holmblad, we're going to have the patient prone or PA in some form, and we are going to flex the knee joint 70 degrees essentially. So that will be 20 degrees off our central ray. Our central ray is going to be perpendicular on the Holmblad to the knee joint, essentially, or to the lower leg with the femur flexed. The femur will be about 20 degrees off from the central ray. But the big thing to remember on the Holmblad is that we have a 70-degree flexion of the knee. Okay. Then the other PA is the Camp Coventry method. So for the Camp Coventry method, we are going to, again, have them prone or PA, and we're going to bend the leg. We'll have the tibia, or the tib fib now, will be flexed approximately 40 or 50 degrees. And then our central ray will match whatever angulation of the tib fib we utilize and center on the back of the knee. Okay, so if we use 40 degree flexion of the tib fib, we're going to center our central ray perpendicular to the tib fib at an angle of 40 degrees. We use 50 degree angle, and it'll be perpendicular every time, okay? Now, moving to the Beclaire method. This is an AP axial, and the patient's typically supine. You're going to flex the knee, put the foot flat on the table. The femur is going to be flexed 60 degrees from the long axis of the tibia. All right, so remember that 60 degrees, and then we are going to center perpendicular to the tibia. All right? Now, those angles will match. You'll be perpendicular to the tibia, though. Just remember that. All right, so that's kind of the method stuff you have to remember. Go through your text, take a mental snapshot of what the diagrams look like. Make sure you kind of understand how those are done, and everything should be pretty easy for you. All right, now on your review sheet, I have your patella, PA, and lateral. Just recognize the patella is basically a knee just coned in. A couple variants on how you center, but I'm not all that concerned with that. In fact, I've never performed a patella in my life. They're very easy to figure out. Okay? So we're not going to spend any time on that right now. Let's go to the femur, though. So the femur is interesting because it's 2 projections, really, but there's 4 pictures that we have to take. To get a full AP femur, we have to do a proximal and distal, and the same is true for our lateral. Let's start. We're going to do these in the order that we perform this, which is AP proximal, AP distal, lateral proximal. All right, for our AP proximal femur, the patient is supine, and we will rotate the leg medially 10 to 15 degrees. Okay, just roll your toes in, 10 to 15 degrees. We're going to attempt to place the femoral neck in profile. Okay, so we rotate the leg in, then we use a 14 by 17 cassette lengthwise, and for all the knees we were using a 10 by 12 lengthwise, okay? But we're going to use a 14 by 17 or the longest axis of our DR plate. lengthwise for the femur. And we're going to place the top of our light at the level of the ASIS, the easy palpable pelvic landmark. Okay? Top of the light there, then we're midline to the bone, and we shoot. For the distal, now we straighten the foot up and down instead of having it rotated. We place it straight up and down like anatomic position, which should place the femoral condyle parallel to the IR. At that point, we move our light field down so that we have 2 inches of light below the knee joint. So pretty straightforward. There'll be plenty of overlap in the middle, and there's that. Then we will roll the patient to the affected side, to the distal lateral femur. All right, we roll them onto their affected side. We're doing a medial lateral projection again, and we remain with 2 inches of light below the knee joint. For this one, we typically pull the unaffected leg over the top so that they can be in a true lateral position. So we take that x-ray, then we move back, we pull the unaffected leg back to the other side again so that it isn't over the proximal hip. The patient's unaffected leg is bent with the foot on the table, and we rotate their pelvis towards the affected side slightly. What that does is allow the leg that we're imaging some freedom to be close to the IR, because most people don't have the flexibility to not do that. So we roll them slightly toward the affected side, then we bend that knee up a little bit on the affected knee, and the leg is all the way out to its side, and again, the ASIS is at the top of our light field. That's it. And that's our proximal lateral femur. So I know it's a lot of words, but it's very, very simple. And the hip is positioned nearly identical in terms of body position, but the centering is quite a bit different. So let's talk about it. For the AP hip, we are going to center, well, we're going to have our patient supine. We're going to rotate the legs in, this time 15 to 20 degrees medially. Then we center, or we're going to use a 10 by 12 lengthwise for this, okay? And we center 2.5 inches. Oh man, that's a mouthful. 2.5 inches distal on a line drawn perpendicular to a line from the ASIS to the superior pubis symphysis. Alright, it's essentially, there's a crease, we've all seen it in lab now. It's easy to identify in person, but you need to remember that verbiage, okay? You'll see it over and over again. It's probably going to be a direction. Alright, so that's our AP hip. Now, one of the kind of consequences of centering appropriately is the ASIS ends up at about the top of the light field, and the pubic symphysis is included right before the medial border of our light as well. So those are some just secondary checkpoints you can mark in your mind when you're positioning for that. All right, so that's our AP, our lateral hip. It's pretty simple as well. We're going to bend the knee up and then lay it out as far as it'll go towards the affected side. So now it's like a frog leg, unilateral frog leg on one side, okay? So we lay it out. The central ray is on the femoral neck. So it's basically the same place, but we turn our tube to kind of match the angle of the leg. And we want to center on the femoral neck. There's no real fancy terminology like there was for the other one, okay? Nothing that I'm going to ask you. I showed you in lab, know how to do it. For the big one's the AP. And then for the lateral, you're on the femoral neck, okay? For the pelvis, which is our final set of projections, we do an AP and a modified sleeve, which is like an oblique or a bilateral frog leg. For our AP pelvis, we lay our patient supine. We roll both legs inward 15 to 20 degrees. This places the femoral neck in profile, keeps them from being foreshortened. We then center, and this is going to be, on a 14 by 17 crosswise. And we're going to center 2 inches below the ASIS, or conversely, it can be described as 2 inches above the pubic symphysis. Either way, we center there according to Merrill's, include the iliac crest down through both trocancers, and also at the mid-sagittal plane. There we are. That's how we do a pelvis. It's very, very easy. And then the modified sleeves, I'm not as interested with how you do this, okay? You don't have to know all that Basically, you bend the legs up, let them fall out 45 degrees at least. Boom, we get 45 degrees, we shoot it, and we've got a bilateral frog leg. Not a whole lot to it. It's pretty easy to identify, but make sure you can. All right, so let's go through the other questions. All right, so the quick questions under the eval portion, or the positioning part, these are pretty straightforward. Why do we rotate the femurs? We rotate them to place the femoral neck in profile, right? So that we can see them, so they're not foreshortened. Why wouldn't we? Well, that's when we think it's broken. And then it asks, how do those fractures present? If a leg is laterally rotated or everted and foreshortened, like pulled up, drawn up towards the trunk, then it's very likely this patient broke their hip. So you combine that with what you understand of the patient's history, if they fell or whatever, and you make a clinical decision. Am I going to do a frog leg? Am I going to rotate the femur? Am I going to do that? And I'm telling you not to. Okay? Shoot it as it is when they present that way, and then you can make better decisions once you've seen the radiographs. All right. We've talked about the best sequence for performance when we're talking about the femur. That's the only one really to regard to that question. And then the medial-lateral projections, these are all medial laterals, okay? The only time this might change is for trauma. You always do cross tables for trauma, okay? And that'll change how we look at it for some of these projections. And we'll cover specifically the cross table hip when we get into trauma and advanced imaging, which is quite a ways away. All right, so let's move into the evaluation. All right, the evaluation criteria is what we've outlined in the book. I'm going to see if I can't bounce this all off for memory very quickly. All right, our AD knee, we have parallel condyles, we have the proximal tibiofibular joint closed, and the patella approximately centered. There's also, on a normal knee, there is equal spacing between the femur and tibial plateau, okay? For a medial oblique, the primary criteria is that the proximal tibiofibular joint is wide open. Secondarily, we have the patella being projected over the medial portion past the medial condyle, forgive me. Those are the criteria I want for the medial oblique. For the lateral, the condyles are perpendicular to the IR. The inferior and anterior posterior border should be completely superimposed. The proximal tibiofibular joint should also be closed, okay? Or there should be superimposition of the proximal fibula by the tibia, however you want to word it. And then we need to talk about under and over rotation of the lateral knee. So I'm going to give you, it's a criteria, it's an if and then kind of situation. So the first thing is, if the anterior and posterior condyles are not superimposed, that portion of them, if those are not superimposed, we know we have an issue of rotation, okay? Then we look to the relationship of the tibia and the fibula. So if the condyles anteriorly and posteriorly are not superimposed and the tibia is completely superimposed by the fibula is completely superimposed by the tibia, we are under rotated. And if the anterior posterior portions of the condyles are not superimposed and the fibula is free or mostly free of superimposition from the tibia, we are over rotated. Okay? That's how we see it. So make sure that that's very clear to you. Now, when we're dealing with the inferior portion, the articulating surface of the condyle, if those are not superimposed, then we are dealing with an issue of central ray placement or incorrect angle selection. All right? Just make mental note of that. We don't have to critique the steady gas or the tunnel projections. For the femur, that criteria is almost identical to the hip, so let's talk about it. For the AP femur, the proximal AP femur, the criteria is the same as the hip. For the distal AP, it's going to be the same as for the knee. But let's talk about the proximal AP femur. All right, the criteria you need for this one is that the greater trochanter is in profile laterally, and the lesser trochanter, if seen, is medial. Okay? Those are the main ones you need for the AP. Oh, and the femoral neck is not foreshortened. All right, that's what you need for that one. For the AP distal femur, it's just the same as the knee. It's actually, it may be a slight variance. All I would say is that the femoral condyles are parallel. If I ask you about that one, that's all you need, okay? Go to the lateral femur. The proximal lateral femur is the criteria for that thing, the hip. It is going to be the greater trochanter is fully superimposed over the femoral neck, and the lesser trochanter is in profile medial. So those are your two criteria for the proximal lateral femur. Okay. For the distal lateral femur, again, it's just the femoral condyles are perpendicular to the IR. That's really all that I'm looking for on that if I ask you that, okay? So then let's talk about the hip. For the hip, it's the same as we just said, but I'll reiterate that for you real quick. Sorry, I'm driving. All right, so for the AP hip, we're just wanting the femoral neck in profile, the greater trochanter in profile laterally, and if seen, the lesser trochanter is medial. Okay? For the lateral hip, the greater trochanter is superimposed over the femoral neck, and the lesser is in profile medially. Okay? That's all I need for that. And then we move to the pelvis. Now the pelvis is going to be very similar to our abdomen when we're looking at rotation. So the pelvis, you know the anatomy is included, but how do you know if the rotation is good? That's the symmetry of the olive, the symmetry of the obturator foramen, those kind of things. We also want the femoral neck in profile. Those are other criteria because we have to rotate the feet, and those are our main indicators for the pelvis. Don't worry about the cleats, and that is essentially all you gotta know. So good luck tomorrow. Shoot me a message over mine if you've got any immediate pressing questions.